And alrighty, so good afternoon, everybody. Thank you for joining us today. My name is Neelab Nori. I am the Environmental Program Manager with the New England Rural Health Association. I'm very excited to be presenting this webinar in partnership with the University of Connecticut's Technical Assistance to Brownfields program. So today we'll be discussing a topic that's often overlooked but incredibly important: engaging rural healthcare providers in brownfields awareness and advocacy. Our goal is to shed light on how health professionals can play a key role in recognizing and responding to environmental health risks associated with brownfields and how to transform these sites into health fields. So I'm also thrilled to be joined by a panel of experts who bring diverse perspectives to this conversation. Alrighty, so before we dive into the content, I'd like to quickly walk through today's agenda so that we know what to expect. So we'll start by sharing a brief overview of the two organizations partnering on this session, NERA and UConn TAB. Next, we'll introduce our panel of speakers who bring a wealth of knowledge and experience to this important topic. From there, we'll move into the core discussion, beginning with environmental contamination as a healthcare concern, looking at how environmental exposures intersect with public health through a case study example. Then we'll explore the concept of brownfields to health fields, a powerful approach that turns contaminated or underused properties into assets that serve health and well-being of the community. And then finally, we'll open the floor for panel discussion and Q&A, where we'll address your questions and hear more insight from our experts. So the New England Rural Health Association is a UConn TAB rural outreach and engagement partner. NERA is a nonprofit organization that serves all 6 New England states, and UConn TAB, which is supported by the Environmental Protection Agency, provides free technical expertise for brownfields assessment and redevelopment. We'd love for you to connect with us on our website, nera.org, join our newsletter, Healthy Lands, Healthy Lives, or become a member and stay connected with us. And now I'm honored to introduce our panelists, a group of accomplished professionals who bring diverse expertise in environmental health, toxicology, and public health. We'll begin with Dr. Kimberly Aviado, followed by Dr. Karen Simone, and then Susie Rule. So Dr. Aviado, I'll pass it over to you to introduce yourself. Then Karen, feel free to introduce yourself, and then Susie.
Thank you, Neelab. Good afternoon, everyone. My name is Kim Aviado. I'm a toxicologist with the State of New Hampshire Department of Environmental Services. I work in the environmental health program where I serve as the department's subject matter expert on the health effects of different environmental contaminants. And I work with a great team of risk assessors and other environmental health professionals.
I'm Karen Simone, a little bit slow on the draw with regard to the unmute button. I am the director of the Northern New England Poison Center. We are the regional poison center for Maine, New Hampshire, and Vermont. I've been working in poison control since 1989. And as time's gone on, in addition to substance use and self-harm, environmental issues have become a greater and greater concern. And our callers are asking those kinds of questions. So we'll address some of that today.
Hi, and I'm Susie Rule, and I'm currently the Senior Research Scientist at the Child Study Center with the Yale School of Medicine, and I'm also on faculty at the School of Public Health, where I teach climate equity and health policy methods. And prior to that, I spent time with the federal government as senior counsel at the Environmental Protection Agency, but worked with 17 different departments looking at a variety of means to address environmental stressors that adversely affect health and well-being of children and families. So I'm really excited to be here. So thank you so much.
Thank you all for the introduction. I will pass it back to Dr. Aviado to kick us off.
All right, thank you. So to kick off our panel presentations, in this presentation, Dr. Karen Simone and I will talk about our respective approaches to addressing exposures to environmental contaminants, with an emphasis on how working together can help protect health. Next slide, please. A big focus for my part of the presentation is on the relationship between environmental contamination and health risk. Environmental contamination is an important health concern because it can expose individuals to harmful pollutants, potentially leading to a range of health risks. For environmental contamination to pose a health risk, three things must be true, and we call this the risk equation. First, contaminants must be present in the environment at a site, so either in the water, the air, or the soil. Second, contaminants must be entering people's bodies through at least one pathway, leading to exposure. Examples include residents drinking contaminated water, breathing in airborne contaminants, or a child playing in contaminated soil. And third, contaminants must have a toxic effect on the body at the concentrations people are being exposed to. On the slide, I have some examples of contaminants and their toxic effects, but I want to emphasize that toxicity is often concentration dependent. Many chemicals are benign or even beneficial at low concentrations, but become toxic at higher levels. So all these things matter when we talk about a health risk. Next slide, please. The reason that this is relevant to brownfield sites is because brownfields are defined by the presence, either potential or confirmed, of contaminants. So in the process of redeveloping brownfield sites, health risk is a critical consideration. But as we just learned, presence alone does not necessarily mean there is a risk, and we'll talk about this more in the next few slides. Examples of brownfields include former factories or industrial sites and areas where waste or chemicals have been spilled or disposed of. These areas can be safely redeveloped if health risks posed by the contaminants present at the site are properly addressed. Overall, the goals of brownfield redevelopment are to reduce or eliminate risks, help the local economy by redeveloping underused properties, and ultimately enhance the quality of life for the community by making what were previously hazardous areas into spaces that can be used safely. Next slide, please. Brownfield redevelopment is conducted in a way that protects human health, and critical to this effort is a process called Human Health Risk Assessment, or HHRA. HHRA follows principles laid out by federal agencies such as the EPA to identify, understand, and reduce risks to exposures from contaminants found at sites. Overall, it addresses the components of the risk equation that I mentioned earlier, which I have shown again on the left-hand side of the slide. Hazard identification uses environmental monitoring data from the site to understand where contamination exists and at what levels. You can think of this as addressing the first component of the risk equation, or what contaminants are present at the site. Exposure assessment helps understand the pathways through which contaminants enter people's bodies, leading to exposure, and who the populations are that would be at risk. You can think of this as addressing the second component of the risk equation, or exposure. Dose response assessment helps understand the relationship between exposure levels present at the site and health effects associated with those exposure levels. And you can think of this as addressing the third component of the risk equation, or toxicity. All this information makes it possible to calculate health risks presented at the site. From there, it's used to inform remediation strategies to reduce or eliminate exposures. Ultimately, the goal is that the site is safe for future uses. Next slide. When we conduct human health risk assessment, we need to consider the ways that people can be exposed through the environment. This image is a conceptual site model, and it's a good reminder of how everything is connected. It looks complex because sites can be very complicated. But the point I want to make with this model is that if we're limiting our assessment to a single pathway, we're most likely missing something. Human health risk assessment typically involves calculating potential exposures to many pathways, including the air people breathe, the water they drink, bathe, or recreate in, and the soil in the areas where they work or play. While this diagram shows how pervasive chemicals and contaminants can be in the environment, I want to emphasize again that the presence alone does not always mean that there's a health risk. For example, in the model that's shown here, if the home was on a public water system and not a well, then people would not be exposed to the contaminant from their drinking water, and there would be no risk from that specific pathway. To the right of the diagram, I've included a list of the common contaminants that are often seen at sites. When conducting human health risk assessment, the specific health effects of each contaminant is considered, as well as whether these health effects can occur after short-term or long-term exposure. So these are some examples of the considerations for health that are integrated into the HHRA process. Next slide, please. So now that you've heard about the HHRA process and how it reduces risks from contaminants that may be present at brownfield sites. What happens if there is an exposure at a site? To illustrate this, let's take a hypothetical scenario where an old factory that used to be used to produce lead paint is being redeveloped. During the HHRA process, it was identified that there's lead contamination in the soil at the site. Until remediation is complete, the site would be closed to public use. But let's say that this is a trespasser scenario where a man and a child are using the site for recreational ATV riding despite the posted signage. The ATV kicks up dust that contains lead, which the child and adult inhale, leading to lead exposure. I'm going to give a quick overview of how an environmental toxicologist and a risk assessor can work collaboratively with clinical toxicologists and healthcare providers to respond to this situation. Next slide. In this scenario, we would be able to share and help interpret information about lead contamination at the site. For all brownfield sites in New Hampshire, data are publicly available from the Department of Environmental Services online portal called One Stop. Anyone is able to access reports and documents about a site. In this scenario, we would be able to access site investigation reports, which would tell us how much lead was in the soil and at what locations at the site. We can help evaluate exposure risk and the possible pathways through which the man and child are being exposed to lead. In this case, the pathway would be the inhalation of lead in dust for the adult and child. We can calculate whether the exposure poses a health risk given the amount and toxicity of lead and can share this information with clinical toxicologists and healthcare providers. We can also engage with the local community to make sure that the risks of the site are communicated. So overall, you can think of our role as providing and helping interpret critical information about the site, the contaminants, the exposure levels, and the potential risks, which can help clinicians make informed decisions about medical interventions and health monitoring. Now I'll pass things off to Karen to talk about her role in the process. Thank you.
So this is where the Poison Center comes in and lends a hand. Usually what happens is a patient gets concerned. Maybe they read something in the paper, talked to a friend, or they don't feel very well, and they call their provider, come in for a visit, describe their situation, and a good majority of the time, the provider is going to find themselves outside the scope of what they're used to managing, and then they reach out. Hopefully they'll reach out to the Poison Center. It's a 24/7 hotline and ask, gee, this is my situation. How do I assess this? What do I need to do? Is this really a problem? And how do I discuss this with the patient and the family? So that's where they are. They call us, and then assessment and management happens. And from our perspective, we're counting on everybody else to tell us what we need to know. I'm not there in front of the patient. The staff isn't there in front of the patient. We count on the provider to tell us what the clinical and laboratory information is that they have at that time. And then that's where environmental toxicology and risk assessing is helpful. The provider and the family usually have no idea what the actual exposure was in terms of how much of what was I exposed to and how bad is that. But I can call the state and get this information from the environmental toxicologist, and that helps us with our clinical assessment so that we can recommend what do we need to look for clinically and on laboratory values to decide whether this particular exposure requires any special monitoring or treatment in the way of an antidote. In the case of lead, it might be chelation with a particular drug. So that would be what we do. And just to bring you full circle around, there's a famous toxicologist. He's really an alchemist in the 14 and 1500s. And he said something that is still important to us today. You've already heard it once. Now you're going to hear it again. Everything is poisonous. Nothing is without poison. And it's the dose that makes something a poison or maybe even a remedy or a cure. So how much you're exposed to is very, very important. Next slide, please. Just a little bit about the Poison Center, because it might not be what you think about when it comes to environmental toxicology. We are a nationally credentialed poison center. These poison centers exist throughout the US and territories. The people on the phones are not someone with 20 or 40 hours of training who reads off of a card or a computer and tells you what to do. It's actually a nurse, pharmacist, or physician who has training, passes national exams, has certification and boarding specifically in poisoning toxicology. So when you call right away on the phone, you get somebody who's an expert, not only in nursing, pharmacy, or physician, you get somebody who has special training in poisoning and toxicology. We are available 24/7, and because times change, you don't have to call us. You can chat, you can text, whatever floats your boat. And we don't just deal with children. If you go back 30 or 40 years, maybe even 50 years, it was mostly 2-year-olds who are swallowing everything they can reach, plants, mushrooms, a lot of medications, and anything in their environment. Lead has been a persistent problem, but there are all kinds of issues with regard to children. But increasingly over time, we get a lot more calls about teenagers and adults through all ages, including older adults and the elderly, with self-harm attempts, substance use, and a lot of environmental concerns. As time goes on, we get calls about lead, we get calls about PFAS and PCBs, anything that might be in the environment, arsenic, radon, uranium, mercury. So those questions or those cases are ones that we can help with. Next slide. Oh, and one more thing before I move this slide. 1 in 4 calls that we receive are now from healthcare providers. So a lot of the calls we get are not necessarily from the patient or family. They're actually from the providers. Now, next slide. What is it going to look like when you call us? We develop a medical record when you call, and when we start a case, we stay with the case from the first call all the way until the patient being managed as well as they need to be and the clinician feeling comfortable. Usually we'll ask very specific questions, the usual age, gender, what do you think the patient was exposed to, how much, why do you think that happened? Are they having any clinical effects that you can see or that they're reporting? What are they? Are they getting worse or better? When did this start? How long has this been going on? We want to know about the physical exam. If you've done laboratory studies, we want to know about those. And in this particular lead scenario, we'd be asking questions such as, how many times did it go to the site? How long were they in that site? Were they wearing any masks, or were they open to the air? In the picture, I think they were wearing nothing, just a helmet, which is good. And we would ask several questions to give us that kind of an idea. And then depending on what we find out, a lot of times what people call us about is not actually what the source of their exposure is. For instance, somebody might call and say, I'm reloading ammunition for shooting. And everybody jumps to the assumption that they're heating and melting lead, and therefore they're inhaling lead from that. Whereas when you find out exactly the procedure they're using, that's really not exactly what they're doing. And their exposure is from being in a shooting range with poor ventilation and not proper cleanup. So, asking some of the questions that we ask, that's all about being sure that even if you're asking us about A, we're not missing B that's obvious and right in front of us if we ask the right questions. We'll also ask basic things about health histories, over-the-counter medicines, prescriptions, dietary supplements, and all of the other things that you see on the slide here. And then if there's been chemical sampling at the site, if there's a site or sampling of the patient's blood or urine, those sorts of things. And what we ask will depend on the scenario. Next slide, please. What can you expect the Poison Center to help you with when you call? And as you can see, I'm giving you an example of what a record on the right side of the slide might look like if we're getting a call from a physician. Usually the information we start with is minimal, and then we'll ask for more information. The documentation will develop over time. But we're going to ask you questions, enough questions that we feel like we can give you good advice. So we need to know enough to be able to advise you. And when you provide us with labs, nowadays, especially with environmental exposures, sometimes patients and families use laboratory results from labs that are known to give information that's misleading and not clinically helpful. And so we're going to start with, what labs do you have? Where did you run those labs? And determine whether the labs that you are starting with are the ones that you need. And if not, we'll advise you where to send your urine or blood or whatever it is you're testing, and how to interpret the labs, which ones you need to order, that sort of thing. And then once we straighten out all the clinical information, the exams, the labs, then we'll advise you on, do we think that this is actually what you're seeing related to the exposure that the patient is telling you about? If so, do you need to do anything? Do you need to monitor them over time? Do you need to treat them right now? How would you treat them? And then we would help you if you need help communicating with a family. In a lead example, some people feel like, I want to come in, I want to get a level, I want to have a treatment, and then I want to be done. And that's usually not how things go. And so they need to understand that there might be some longer term monitoring going on and why that would be. So we're there to help with all of those things. And of course, we will be much better if we work with the environmental toxicologist and risk assessor to help us with what do we think that exposure actually was. Next slide, please. Back to our scenario. So the question is going to be, is this a lead exposure that is concerning or not? We're going to need a lot of information on clinical flex and labs. And then again, this is repetitive, but hopefully it will stick better. We're going to help with treatment monitoring. And then there's a question of secondary contamination. Did they go out, get covered with lead dust, and bring home that lead dust to the house? It's all over the house, and the 2-year-old is crawling through it, licking their fingers. That would lead to more interventions and maybe more testing that we need to do. And that is what I have.
Thank you both. We will pass it to Susie now.
Thank you so much, NELAB and NERA and UConn TAB for providing us with this opportunity and this great foundation that we've already just heard about the specific relationship to contamination. I want to pull the aperture up a bit and talk to you about a very exciting and powerful pathway that exists for us today to advance the well-being of children and families and communities who may be impacted by, potentially impacted by contaminated sites, and look at that as an opportunity to flip the triangle so that we can turn that into something that's good for that community. And the arc that we apply is something we call triple bottom line justice, with the end goal being environment, health, and economic well-being. And then realizing that in order to get to the right decisions, you need to understand what is the legal framework, the rule of law that guides actions, what is the evidence, the hardcore scientific evidence that we just heard about to help inform those decisions, and most importantly, how do we engage the people who are experiencing that decision-making process, so again, that we're looking at that sustainable, resilient community well-being. Next slide. So under the arc of triple bottom line justice, there is a very exciting, very balanced approach that has been successful over multiple decades, and we call it Brownfields to Health Fields. And that's the concept of taking Brownfields redevelopment up a couple of notches and really reverse engineer from the solution of what we want that site to become, and making sure that that site is promoting the well-being of the people who are living in that particular area. And it's looking at the World Health Organization definition of health, not just the absence of disease, not just access to care, but healthy foods, healthy green spaces, sustainable natural ways to deal with contamination. And this is the concept that was actually developed when Brownfields was first created in the 1990s, the Brownfields Authority. And it was co-created by people living around brownfield sites, with government at the local, state, and federal level, with the private sector and brownfields redevelopment, with nonprofit organizations, with academic institutions. So it's been a tried and true approach. And again, the key part here is looking at, again, trying to achieve environmental protection, health protection, and economic vitality. And the three essential components are, starting with the brownfields, you want to get that site remediated. You want to reverse engineer that site from what it can be used for in terms of addressing basic needs and safety and overall well-being. And what's vitally important to this process is including the people who, again, who are impacted by that site, and who may be underserved in that particular community for healthcare needs. So this is the concept. This is the pathway. Like I said, it's tried and true, and it's a very viable opportunity now. Next slide. It's exciting to say, like I said, Brownfields to Healthfields is a collaborative approach with multiple stakeholders. And over the last couple of decades, we have applied it very successfully in rural communities. For example, in the Appalachian region, in Central Appalachia, we were able to work with local optometry schools to create vision care centers on former gas stations. Going to Southern Appalachia, we worked with them to repurpose old buildings. We worked with an abandoned high school and turned that into a community center that provides mental health care for children and families. It creates a venue for recreation and community gathering. And then we also had a 26-mile railroad track that we turned into the Mountain Goat Trail that actually provides diabetes care. So again, we have really exciting examples of the application in the rural area. The most recent example and success story here in the New England area is what we call our Mount Trashmore to our Mount Growmore success story. There was a 30-year-old abandoned landfill in a neighborhood in the east end of Bridgeport that is low income, people of color, incredibly high rates of disease disparities and low economic vitality. And in the course of 3 years, working with the Brownfields program, with EPA and with the state of Connecticut, the UConn TAB has been a player in this. The Yale School of Medicine and the School of Law and the School of the Environment have all participated, to where we're turning this into a hydroponic farm, a wellness campus, and a learning center. And because of its connection to environment, to health, and to economics, we've been able to leverage almost $4 million in a federal earmark with state bonding money. Again, EPA and Connecticut DEEP have provided invaluable support through technical assistance to make sure the site is properly remediated and is protective. And as described before, that the exposure pathway has been broken. So this is an exciting new model that's coming out of New England that can really serve as a learning example. Next slide. And finally, I think that we are in such an important time right now with the increased focus on rural health, with new legislation that is coming out of Washington. And I want to say that I am mindful of the larger discussion about rural health, but it's important to know that there is authority for $50 billion for rural health that's been made available through an amendment to the Social Security Act. And this funding, as many of you probably know, will be allocated to the states over 5 years, with half of that money being distributed equally among the states. So each state should be getting $100 million per year for 5 years. And this funding, when leveraged with Brownfields to Healthfield, can provide an incredible opportunity to, again, reverse engineer the health challenges that are related to environmental exposures. But it's also a chance to leverage additional funding that is available from the federal government to clean up these sites. And so the funds can be used to improve access to the hospitals and other healthcare providers. It supports evidence-based interventions. We've heard about the important role of lead in rural communities. Brownfields and lead, as we've heard, are relevant. We can perhaps use this funding to create new health clinics and health access points, as I've described in Southern Appalachia. So I think that this is the beginning of this new conversation about the linkage between rural health and brownfields redevelopment. And I look forward to increasing conversations with all of you on the phone, on the Zoom call, because we're at a point now where we can all co-develop and co-create this new exciting opportunity. And if anybody happens to be going to the Brownfields conference in Chicago next week, we'll have a couple of sessions on this, and please let us know. We'd love to have you engage in this process. But like I said, I think that there's the downside of having contamination, but we are in such an exciting opportunity with Brownfields to Healthfields to really help restore communities to vibrancy. So thank you very much.
Thank you so much, Susie, and all of our panelists. Thank you so much for sharing your insight and your perspectives, your expertise. I'm sure we all greatly appreciate it. So I know we are very short on time, so I will just quickly throw out there, if anybody has any questions or would like to engage in any discussion, feel free to go ahead and put it in the chat or unmute yourself. We can take those now. Okay, we'll wait another minute, and then after that, I think we will give everybody their time and really appreciate you all being here today. Thank you so much.
Neela, while we're waiting for people to ask questions, I know that we'd had a discussion about what are some mechanisms that community members can take to get involved in this process. And one constant method that we've been using with our Brownfields to Healthfield program is something we call breaking bread for B2H. And that is where we set a table and bring in the whole range of stakeholders, whether it's a local government, whether it's a healthcare provider, especially the community members, bringing in our academic partners, and basically start a conversation about, well, what are the challenges? Not just start with, well, there's a contaminant that we're concerned about, but how do we restore health and well-being to this community? So it's called Breaking Bread for B2H. It's a constant platform. We can bring in, like government that has resources, so on and so forth. So I wanted to say that that is a mechanism that's in play for Bridgeport right now with Mount Gromor. We're doing it with Southern Appalachia. So that's a vehicle for people to get engaged if they want to get started with Brownfields.
Thank you for sharing that, Susie. Well, it seems like we don't have any questions. So this webinar is recorded. So